while reminiscing about diving under tables to save myself from the nuclear holocaust, I was also thinking about my early days of taking care of patients with stroke, where you had to tiptoe around the hallway and the patients were put in a quiet room, and 3 weeks to 3 months later, the often arrogant neurologist would say, well, what you see is what you get. Times have changed, but perhaps mostly because of a set of animal data that are best captured in this experiment by Randy Nudo and his colleagues in the mid-90s and late 90s, where monkeys were trained on a task, and the task was calculated and measured by the array of a mini end plate potential in the region of the limb that was moving. And then monkeys were randomized to a rehab group or a no rehab group. And happily for us, the monkeys that had the intensive treatment seemed to do better with their re-innervating of this hand and a map, such that it expanded into a variety of regions not normally associated with a hand, and those left to much more minimal experiences had, in fact, regression of their injury. Well, this led us to form a collaboration with a group of engineers at MIT who at this time were developing a motor that was interactive, so that if you actually move this motor, it would turn off while the entire system was still recording the sensory information that was being fed into the motor. And we designed with the MIT group a series of robots that actually act as exercise devices. And what I'm going to try to convince you of in the next few minutes is that if recovery after stroke is measured by any of the number of molecules that you've seen today, or novel drugs or cell-based therapies, I would argue that the central nervous system that's broken and now is being repaired by these molecules is still going to require some form of retraining, and that robotics are these candidate tools that will deliver reproducible, intensity-controlled retraining and also provide objective measures. Now at the Feinstein, there are 5 of these devices. 3 are installed here in the Feinstein Institute, where we're running a couple of NIH-funded studies in trying to affect the outcome, the paralysis outcome, motor outcome of people who have had chronic stroke, and a couple of devices now as we move from the shoulder and elbow, where we've had some success, into the wrist and hand, and now into the ankle, and into anti-gravity moves in the shoulder installed out at Transitions, which is a place where our patients are taken care of. The mother robot, the mother load, was it looks like this, where the patient sits in a chair, looks at a visual display, has their paralyzed arm in a manipulandum that has a trough, and the robot will move the patient if the patient can't move, and as the patient moves, the robot gets out of the way, and then very quickly begins to assess how good the patient is at speed and accuracy of trajectory, and begins a series of interactions with the patients where the movement is corrected, made more accurate and made more speedily. And the system is such that the patient is sitting in this chair for 40 minutes or so, 50 minutes, and 1 hour of therapy every other day for 12 weeks seems to, and the number of movements per session is over 1,000. It seems to in the early studies, it seemed to be successful. And so this is what a typical setup looks like. We had 10 years or so of successful trials. Patient looks at the screen, moves the manipulandum to points on the table in front of them that correspond to the vector points on the video screen. And the kind of changes that we're measuring, these are patients who are 6 months after stroke. We're altering a standard disability scale called the Fugl-Meyer that's worldwide. We're changing the results by 3 to 5 points, and this is significant in the patient in terms of the patient's disability. It's allowed people to be able to dress themselves and begin to bathe themselves. We focused on upper extremity because most people will walk out of the hospital after a stroke, but very few have any natural return of arm function. And just to show that the studies, the preliminary studies were leading us toward the controlled multi-center trial, which was successful and was published a couple of years ago now, where we took 120 patients across 4 veterans hospitals. And I know this graph is a little complicated, and some of my friends have reported that people have a little trouble understanding that the effect is positive, so I thought I would just go over it quickly. This is the motor scale outcome, the ability to move again, the mean change over time. The active therapy is 12 weeks in the beginning here, and the blue is the robot treated versus usual care. And you can see that after the therapy is stopped, the robot effect continues, and overall it's significantly different from the usual care. We did not have the luxury of a run-in time, so this first group of patients, 25 or so on each side, was our essential run-in time. And when we got this significant effect, we were able to now generate a positive control for the robot. And so when people read this paper and they look at this red square, they say, oh, well, the robot is not different from the red square. But that's precisely the point. What we were trying to do here was generate a positive control whereby we could show that a therapist working to mimic the kind of intensity that the robot delivered could also generate the delta. And now the significant change is to look at this robot group, the change in Fugl-Meyer versus the standard of care is nearly 5 Fugl-Meyer points. We don't think that this positive control therapy is one that can reliably or usefully be transferred to the clinic, but in performing the positive control, we're showing that there's nothing really magical about the robot that a person couldn't do except, or that a therapist couldn't do except that 8 hours a day of this kind of 1,000 movement trial is not clinically feasible. Well, these experimental results set up a number of different issues that have to do with motor improvement after stroke. And one of the problems that therapists have is performance plateaus. Another is whether you can actually optimize the human-robot interaction, whether there's a way to tune speed or accuracy, and whether that can be tuned across patients with different lesions. The other is if you're going to train a person to alter their performance based on your training task, will that generalize to other tasks? And then I've told you a little about the positive control. That is, can you just mimic what the robot's doing with standard care? And then finally, It's to remind you that the robot it can be an objective measurement tool. Let's just focus on one or two for today. And first is to show you some issues of how the robot actually adopts the performance-based training. You can see that after a couple 5 moves, what the robot will do is generate a virtual trough that directs the patient toward the goal, and that this trough can change its speed and alter the patient's movement toward the goal. And the patient will tell you that they feel the robot moving them, and then will tell you that they feel the robot challenging them. And it's these two aspects that make it simple to have the patient participate in 1,000 movements. I mean, think of yourself on the elliptical. If you didn't have the television in front of you, there's no way you would do more than a couple of minutes. These kinds of little tweaks have been important, and it's what makes me think this robot is the best device around for upper extremity. What you see in these two videos, let's see. The yellow is showing you the spongy slot, and it's showing you that it's speeding the patient along by pulling the ball is the position of the manipulandum on the table. And this spongy slot is showing you that the robot can be tuned to accuracy as you see the ball bump up against the side of the yellow moving slot. And so we took 100 patients and we trained them according to different robot tuning devices. Performance-based is the strategy that trains accuracy that trains trajectory. Intense standard sensory motor spring trains power. So in this case, the robot guides your trajectory to the target. In this case, the robot makes it harder for you to get to the target. And in this case, the robot makes it harder for you to get to the target. And in this case, the robot doesn't really care how accurate you are in your trajectory, and it also doesn't care how fast you move, but it is performing the movement for you if you can't move, and it's getting out of the way if you can move. And what you see on the right column is the change from admission to discharge in this Fugl-Meyer scale. So with the accuracy training, we were able to alter the Fugl-Meyer scale by 7 points, and the strength, the power training by 4.5, and the standard sort of where the robot isn't doing much of anything except getting out of the way if you can move, but it's not really challenging you. We get a baseline 4.5% change in the Fugl-Meyer. Intensive training was, we thought, well, if we can do this one time, 3 days a week for 12 weeks, what if we did it twice a day for 6 weeks? And what happened was we shot ourselves in the foot. Everybody was pretty exhausted after 1 or 2 days of this intensive training, and the results were worse. This is to show you that the robot is an exquisite measuring device, and it's taking that data from 111 patients and now generating objective measures, namely aiming, accuracy of trajectory, speed, and force. And you can see that the performance-based guidance, where you're training trajectory, significantly improved the aiming as its major kinematic improvement. And those with the standard spring just got speedier, but not really much more accurate. And those who were trained with a spring of increasing resistance improved their force, but not much else. The fact that the robot generates these objective measures has become clinically important, as we've done a study with Johnson & Johnson that's recently published, where we showed that if you use these kinematic objective measures, you can decrease the number of patients that you need in any particular study. These kinematic measures correlate with clinical measures, so we're not measuring something that's not useful for clinicians. Let's look at whether the training in reducing the impairment and the training of point-to-point tasks can alter the performance of an untrained task. One of the things that we typically do with patients is that we ask them to draw a circle, and you can imagine that a patient with hemiparesis would draw a circle that's fairly elliptical and fairly close to flexor spastic responses. And this is what happens to that circle after training. And if you measure this in an experimental way, you can begin to look at shoulder and elbow excursions so that you can measure joint angles through these movements, and you can make two sets of measurements. One is the correlation of the joint angles as the patient draws the circle, and the second is to measure the major. Well, with a circle, it's to measure the two diameters, but essentially in an ellipse, it's to measure the major and minor axis, and to test what happens to the relationship of the major and minor axis. And in the array on the left, you see the axis ratio. One is the perfect circle. This line describes the admission axis ratio for 111 patients. And the line that moves away from this admission line is the final excursion of patients as they draw the circle, and these are significant results. Also, the joint angle correlation for you and I, the correlation of joint angles is pretty low because we do things differently each time in a task like drawing a circle. And so what you see here is the admission values for the joint angle correlation, and then the triangles or the diamond shapes that are distant from that admission line are the discharge correlation joint angles, and you can see significantly the patients have dropped that joint angle. Another mark that what the robot is doing through these intensive experiences is retraining something that's really useful movement and the kind of control over limb segments that is much more toward normal. Now, the robot is also a platform, and what we're in the middle of thinking about now is how to take the robot and add brain stimulation phenomenon. And one of the current studies is to test whether transcranial direct current stimulation leads to greater impairment reduction. Johanna Chang is working with me on this project. We got involved with transcranial direct current stimulation by applying it to patients and finding that that after the transcranial direct current stimulation, we had increased the motor end plate potential in the cortex to median nerve activity, and that enhanced activity was something we also saw post-robot treatment. So we set up a study where we gave the TDCS after motor training, before motor training, and during motor training, and then a sham task. So they were getting the TDCS around the robot activity. And what you can see is that training alone and TDCS before training improved mean speed and smoothness most significantly. The training during TDCS, or TDCS during the training, actually caused a decrease in aiming, a worsening of their trajectory, and then when the TDCS came after the training, they became much slower, as if the TDCS had exhausted them. And so it was apparent to us that TDCS, which is a microamp of current delivered anodally and cathodally across the skull, has the potential to augment or disrupt, be adaptive or maladaptive, but combining them in the way that our preliminary data shows, that we'll test whether TDCS before robot training gives us an enhanced robotic effect. There are a number of people who've helped me along the way. Krebs is my MIT colleague, and Johanna, Pato, Maureen, Myra, and Nicole have all been through the robot lab. We have some support from grateful patients and from some public sources. Thanks. Let me answer questions.